Thank you, sir. So, while taking the advantage of the presence of the dignitaries, we're going to start our second session, that is AI for Health Country Perspective. It will be chaired by Dr. Thomas Vagan and Dr. Chandrasekhar. And I would like to invite our first presenter, Dr. Deepak Talwar, who's National Security Advisor at Microsoft. Dr. Deepak. Okay, so may I request the dignitaries to take their seats in the main hall, the front row. And the chairs could continue sitting here. So would you like to sit here or? Yeah, I think because you can. Okay. Yeah.
हम लोग भी इसमें इन्वॉल्व नहीं हो पाए और ये कभी उन्हें भी कभी इसे इन्वॉल्व करने की अदरवाइज आइडियाज
So let's start immediately. I'm noticing we are mildly behind schedule. Our first speaker will be Deepak. Maybe in the interest of time, could all speakers please come to the front, if possible? So Deepak Talwar, Harsha Jaya Kodi. I'm training my Indian. Helmi Sakkar. Yeah. Oh, so you think because people want to see the screen, or?
It is possible. In case that suits.
Okay, that's fine. That's fine. Okay, so then please stay where you are, and so let's start. So Deepak is coming to us from Microsoft India, and I shouldn't be spending much time. You should spend the time to tell us what you want to do.
just come.
Should we dim the lights or should we leave it like that? Well, dimming the lights has the danger of people falling asleep. So yeah. While we wait, other questions? If you have a question, now it's the time to ask it. Oh, now we can start. So too late for your question.
Hi, good morning. Hey, good morning.
Good morning.
Thank you. Being the first speaker to start with, first of all, thank you to ICMR. Thank you to all the members in the room. I would like to have a little bit of passion in the room because it has been starting with a national security officer of Microsoft. And there is nothing better which we can send. By the way, it's not Dr. Deepak Talwar, it's only Deepak Talwar, right? And this shows us the combination of technology coming at the first place at the center while we are talking about artificial intelligence in medical, healthcare, and life sciences, right? This shows also the combination of the era where we are talking about not just the technology or its use in the best way, in best possible way, keeping in mind we also help individual citizens, and especially in this room, we call the patients like all of us. We are suffering from one or the other disease. One of the diseases, mobile disease, right? So we will try to do a balance of Microsoft AI for healthcare. As of today, we thought of introducing you to something on the era of imagination for artificial intelligence when we are talking about being a patient, being a clinicians, being a provider and health organization. If you really see, if I get the information for my family well on time, right? Whether it is technology, through people, through process, things can transform till the level we can save the life, right? If it is clinicians or administrations and we are able to give the right information by treating the patients based on the technology as artificial intelligence, life can transform, right? Something which is unknown is a known factor of AI. The providers which we talk about, analysis on the patients with the precisions, right? And with the quality of information which can transform with the connectivity, whether through medical equipments, whether it is talking one doctor to a remote locations, or even when we are talking about people to machines, things will change. And the last one about health organizations, if it can harness the power of data, which we heard in the morning a lot, and the precision of the data, because data, big data, the classification of data is too high. The information is too many places, whereas to classify the right information at that given point of time for doing a medical surgery can optimize the cost, it can optimize time, and definitely it can save the life, right? As an individual, earlier, from a childhood, what I've learned being going to doctors is I don't want to bear pain, right? And that's also my family, and that's also all the citizens worldwide. I would like to put minimum time in the rooms, the minimum efforts, right? So when we start from the home to meet a doctor, it takes 4 hours to complete my process for a 10 minutes of meeting with him, right? And get the consultation. So optimize that 4 hours into precision, getting the quality, even if I am living, doing the country perspective like India, where we have maybe around 650,000 plus villages. 800 million people in those villages is one of the perspective of India when we talk about rural India or connected to urban India. Everyone needs the medical information. Everyone needs the same level of, clarity that what they need in their body to be cleared by the doctors. And that's where we see the healthcare is rapidly transforming. Whether it is chronic disease, if we get to know, it can be national epidemic, which can be stopped. Because as we heard from Niti Aayog as well, that while doing an AI transformation and having a blueprint, it may have a national impact of doing a self-inflicted disease. It may be cancerous to multiple people who are not aware at the right time, can also do the patient ingoing and outgoing. So what is artificial intelligence? I thought it will be a very simple liner which talks about more of the amplifying human ingenuity with intelligent technology. What does that mean to us is it is all about human intelligence which we can amplify for reasoning so that we can get anything which is having a data and it can be classified to a perfect level which is an imperfect data, finding the reasoning from AI. By writing algorithms, I can understand and interpret any text, any message, any images. In this room, we have heard the images plays a very important role and the recognition. We can take an images from an X-ray to the digital images for any of those, access or data information. This can be transformed into a regulated way and information stored well at a place, and it can fall prey to any of the activities for interactions as well. So we are amplifying human ingenuity, evolving with intelligent technology. And that's how we do it. But we want to take a minute here just to explain, why are we doing it now? Is this something artificial intelligence very, very new? The answer is no. It came earlier in the era where it could not be understood well on time. But today, if we see, we started with mechanical, moved to electrical, getting into a voder, getting into a calculator, transformer, and computers. As an organization, even as worldwide, we all understand the word which was talked about artificial intelligence in the morning was three things. I'm just qualifying with data to big data, compute powers, and especially about powerful algorithms. If you combine, you get that today. So why it was not done earlier? Because you were having scattered information to use that intelligent machines on that moment. But today it is reality because data has grown high, right? With this getting into a little bit of evolution part, how we have done that, this is one of the reasons why we are sitting in the room talking about proactive engagements with the patients. A realistic view, an approach which is realistically absorbed across the world, including India, is getting into a tracking of patients' health. It can be creating the digital asset for me as an individual, and I have my whole care plans. I enter into my known defined hospitals, it are interconnected, and I'll be able to intelligently search my entire scheduling and appointments, and even do a personalized notification, including my emotional or imbalanced behaviors, which can be intelligently transformed while I enter into the medical room or hospitals. That's the way we are looking forward in terms of proactively engaging with the patients. By the way, if I can say so, it's patients which are at the center now, not the doctors. The doctors can come to the patient where remotely you cannot even have a road to commute at the same time. In a minute, we were able to connect and get the access in this room virtually across the world. At the same time, we may not do in a rural area of a village in communicating for a surgery going on right here and learning in that village. It's very, very impossible situation. But with this artificial intelligence, I can create algorithms, do the connectivity of human and machines at the same time, and able to give the live informations, including the coordination efficiency of patients and care systems. One of the reasons which we have seen AI in trackings is more to do with digital assistance, especially in nursing. The information where we see, I heard this word that it should be cost optimization. The medical research and AI should not overload the patients, doctors, and the community. How do you optimize? You optimize based on the people, process, and some of the technologies. I can have digital assistance, and by no way this means that we are relating or removing human beings. It was rightly mentioned in the morning, human beings is the intelligent brain behind the technology. So it will continue to evolve in AI, rather it is multiplying day by day. So you engage a digital assistance, record, transcribe, and you can create the complete patient history. And by doing that, you are actually intelligently recommending what should be the next step in that individual behavior with an umpteen limited time. It did not take more time for efficiency. It's very, very critical while we are thinking about applying AI. So I have reached a stage of applying AI in a clinical operational effectiveness. What we have seen is any of the prevalent diseases, we do not have data today. If that data is there, it is not at one place. If it is one place, we don't know what is the inference out of that. Artificial intelligence is helping to identify a specific area, maybe in cervical cancer, and you are able to identify pinpoint areas, which is the precise way to track and create a public health epidemics to the next level, and you can minimize that as a populated area as well. Now, enable connected device to monitor condition of critical care equipment. That's very, very critical about the medical history. We saw equipments which are used in silos. Now the equipments are interconnected. You do not just get an MRI done and you just leave it there in the data storage locally. It gets intelligently transformed into the system. And while machine learning, one of the application of AI is machine learning, we are able to put the known algorithms and after that it self-learns. That means it can self-learn humans. It can self-learn through the machines and devices which are intelligent enough. By the way, a caution, it can be internet protocol driven. It is related to IP, it is connected to internet. So it has to be digitally safe. It has to be encrypted. So I might have live information on my devices transmitting, inter-transmission within India and to the global region. And it is actually giving a recommendation live in that room. It's real today, right? Thank you for bringing some words that AI, cloud, intelligent data storage. We are talking today on application, not that whether it is accepted or not, it is well acknowledged. One of the aspects of transform of care continuum, where we see the visual nursing, as I was talking about for the visits, and learning models to expedite the potential findings. These all are live applications going on, not in testing, but being utilized. I'll qualify that further. Being a security officer and seeing the privacy as being brought very, very, very specifically, I wish I can say AI is data. It's about information, algorithm, and rightly mentioned regulations. It is true, there is no independent other than HIPAA and other regulations which can talk about. But let's step back. When we talk about regulations, privacy and all, the laws or information to store data or to utilize data were also in legacy. And now we are using artificial intelligence. So we need to look back and revise some of the laws and regulations to identify and build it together, which can have something like privacy by design. You'll hear these words, quite often. Privacy by design means as an organization, as a practitioner, we will make sure that when we design it, its part is in bold, not on bold. It's inside. So with that, we always believe the strength in technology and compliance plays a very, very important role. Now, let me address some of the Indian-centric things just to avoid a few more examples and take you through an Indian-centric requirements and the reasonings of cervical cancer in one of the hospitals, and even for the network or cardiology, doing with the Apollo testing, even for the global impairment of any epidemic on the visual impairments. These all are India-centric activities where we have seen that you can even go one level beyond to find out how to stop cervical cancer or at least detect cervical cancer well on time. Similarly, the visual impairment, one of the worldwide epidemics and seeing in India horizon as well, you will be able to get the tools which can minimize and can have an early precursor for any of the cancerous or other disease. Global or in India perspective as well, one of the dyslexia in the kids, right? If they get on time, and how do we do it? You pair artificial intelligence, put hundreds of kids in front of machines, it will be able to detect whether their dyslexia activated or not. And by this parity, we are actually leaving toward the accuracy to get into optolexia, so that we can find out if you are having dyslexia, this is the course of action which they need to follow. And it definitely brings the encouragement as well for kids to grow better. I will avoid this video. It was more to do with what is insurance. I've covered privacy and security, but just to put some key consideration, the data protection, privacy and transparency law, and even the conduct the security and privacy review has to be part of every equipment, every device, and every protect AI systems which we built on. So with this, we see a lot of cyber crimes happening in the same field. I thought I'll not miss that piece. Any of those coordinations, you need to have encryptions, you have to have patient preferences, data collection, storage at the appropriate time. It can be with you, it can be on internet, it can be on cloud, it can be digitally anywhere. But it has to be safe, secure, and follow the compliance. The last word in my last 30 seconds I would like to leave, when I heard the word ethical AI, right? From the organization perspective, we are very, very sincerely, or even for the community, the word is responsible AI. You need to be like a responsible citizen. You bring in the proximity of human with the pace of innovation. With vision started, today we are doing language understanding through digital things of intelligence in 2019. You need to bring responsible AI. I would avoid some of these charts, but it is important on the responsible AI about fairness, reliability, privacy, transparency, and accountability is built in when we talked about the communication of the responsible AI. And this is how you see when we detect and you are able to adopt the recognitions of each face, you are able to do the accountability, a lawful surveillance as well if it is required by Government of India or anywhere in the government, a notice and consent. Without the consent, I should not be sending and accepting the information, a non-discrimination, right? A fairness and agility, empathize and transparency. So this is AI for good. To conclude, being the first comer, India is in third rate of AI skilling, the third skilling. As an organization, we have around 10 AI labs, and we are trying to transform with Niti Aayog and the members of Government of India to play a role for AI for good. Thank you, everyone.
Thank you. Any one question we can do. Okay, it doesn't seem to be the case. So our next speaker is Harsha Yayakuri. And yeah, I know. And we this is the fate of those that come late, that those who took the time prior to them caused them to take less. So please stick to like 10 minutes if you can. Thank you.
May I request the speakers to maintain the timelines? Yeah.
Good morning, everyone. I am Dr. Harsha Jayakuri. I am from Sri Lanka. So I'll be talking about how AI for health in Sri Lankan country perspective. I'm a medical doctor with 12 years of experience, clinical experience in the medical field. Out of this 12 years of experience, I have worked in many areas, subspecialties in government as well as private hospitals. And I am the founder of MyDoctor.lk, which is a digital health care platform which connects doctors and other stakeholders like pharmacies, labs, and with the consumers. So I founded it in 2012 as eDoctor. Then I actually got some funding, and then with the Dialog Asiata PLC investing, I changed my brand name to MyDoctor.lk. And so today, we are the pioneers in Sri Lanka. So just to give the Sri Lankan perspective, in Sri Lanka we have government public funded as well as private funded health sector. So mainly our majority is the public funding because it's free of charge for all the citizens in Sri Lanka. So if we get outpatient department, we see around 48 million of outpatient visits happen per year, which is around 65% of whole segment. And in the private sector, it's around 33%, which is 24 million outpatient visits happening. And when we take the inpatient visits, we see it as 95% of inpatient visits have happened in government hospitals, and only 5% happen in the private sector. So why I want to tell this is the actual problem in Sri Lanka. So because of this free health, all the government sector hospitals, state sector hospitals, and other state sector medical clinics are overcrowded. So sometimes the care may be reduced because of a lot of waiting time, then unable to reach certain specialties, and also in Sri Lanka, the specialties are not all over the country, spread all over the country. So it's mainly the Western province, which Colombo is there, and the other rural areas, they don't have proper facilities. So that is the main problem. So in Sri Lanka, we had few milestones just to tell you. So in 2015, we started this digitalization of health records in government as well as private hospitals. So it was the first digitalization happened before this, but as a policy, government policy in 2015, this digitalization happened in the health records. And then telemedicine platforms were introduced even in government sector in 2016. And towards the 2018, the big data analysis was done, initiated in most of the areas. And in 2019, actually, the prediction modes were initiated, like teleradiology, teleophthalmology, where predictions with the aid of the data, as well as giving decision support, like through teleophthalmology and also teleradiology, where consultants can give their inputs. And in 2020 and above, we are looking for this AI through these cognitive applications, as well as proper predictions. So if you get around what are the world, just to give you a brief idea, so for diagnosis, and then as chatbots and surgical robots, so those are and there are certain opportunities in Sri Lanka, so which we have identified. So I'll quickly go through that. So as I told you, due to higher waiting time in Sri Lanka, especially in the public sector, we have identified that if we have certain chatbots or virtual assistants through AI, we can actually reduce the waiting time in a lot of these hospitals. And also the shortage of medical services, which I told, it's not spread all over the country. So with the aid of AI, we can actually predict what are the services needed, what are the human resource power needed in these other areas also. And also with the aging population increasing, especially in Sri Lanka, we can use AI for this reducing the NCD of this aging population. And also when it comes to mental health, so we have started doing a few researches where we can detect people's what they choose in a sentence or what they use in languages, and predict the people who will go into depression or who have certain stress. So we can reduce the number of people who will occur mental illnesses in the future. And also for counseling also, this AI based systems can be used, because people feel more comfortable and also to have regular care. So I have identified, we have a few challenges. So like low data quality and less data quantity in most of these systems. So we have to address that. And then people have wrong perception in Sri Lanka about their job security. So we have to educate people on how AI will increase the jobs and how opportunities they will get, what are the benefits. And also we have a lack of trained staff and lack of understanding among technical staff. So that also we have to train them. And also the in private sector, we have seen lack of business alignment with the AI. So some people think that AI is not, it's a futuristic, but always we have to be futuristic when it comes to healthcare. So that is what I just want to tell you. And just to give you in prehistoric Sri Lanka also, there were there was King Ravana in Sri Lanka, which in ancient things they tell that there was this Pushpaka Vimana where AI was used as machine learning. Thank you very much. Thank you for inviting me.
Thank you very much for very comprehensive and very informative experience of Sri Lanka. Any questions for them?
Thank you. Now we invite the next speaker. The next speaker is Dr. Helmi Zakaria from AI in Medical Epidemiology, Malaysia.
Thank you very much, Chairperson. Hello, hi, good morning, everyone. My name is Helmi Zakaria, and I am from the startup we call artificial intelligence in medical epidemiology. Is a mouthful word, and usually people don't get what it is. So I'm thankful that we have a lot of doctors inside here. I myself am a doctor, and what we try to do is that we try to change the paradigm of public health. We try to change the paradigm of population health from a passive surveillance into an active mitigation approach. I am not alone in this journey. I am supported by two of my best friends, Dr. Desi Baharaja and Mr. Rainier Malol, who can't be here. And in showing you this slide, I actually want to point out three important factors. That number one, all of us were partly in government before. I myself worked with the Ministry of Health for many, many years. And after that, I worked with the WHO for a couple of years. So we have been in the regulatory part of the world. And now we are doing what we are doing. Number two, all of us venture into innovation with public interest in mind, because I think that's what we millennials are supposed to do. That sustainability become a big and important thing to us. And number three, by itself, we are interdisciplinary in nature. So as you can see, we are not like some, I mean, contrary to some people thought that we are not this like rogue entity that move around and collect data and develop something. We have been working very closely with the government from our early inception. And I think this is important because that is only the way how you can build something that is practicable and applicable immediately, and to answer a question that is urgent and imminent. So as you can see now, we operate into an operational center, and we have a combined 35 years of experience in public health, telematics, agriculture, and data science. And I will let you know in a bit why it's important to have this interdisciplinary nature. But before that, let us focus back and take a step back and try to understand what is it that we try to actually solve with AI. What we try to solve is uncertainty. We try to remove the uncertainty of whether you are going to buy into that advertisement. We try to remove the uncertainty whether the tissue that we are looking is benign or cancerous. And at least in our case, what we are trying to remove is the uncertainty of public health outbreak, of disease outbreak, where it will happen and when it will happen. So at least in our case, we firstly focus into vector-borne disease, which is dengue and Zika. And when it comes to dengue and Zika, 400 million dengue cases are registered annually. There are about 1.3 million Zika cases so far that we estimated, but it means like 2.5 billion people are at risk. This means they are about 40% of the world population. Having said that, the investment in dengue and Zika is equivalently not that high. I know this seems like a very big number, but while I was working in the WHO, my portfolio at that point of time was to champion the dengue agenda, to champion the vector control management, to basically help to solidify more investment and tools and new approach in vector control, because dengue is a very middle income problem. It's a middle income country problem. It means like you are not that rich to come up with your own solution, but at the same time, you are not that poor to actually get some funding or actually some solution. So unfortunately, at the current response, our current response is still very passive. And while the human costs of epidemic are going down, but the economic costs are definitely going up. And why is this? This is the reason because like we triangulate our outbreak and we try to identify the place that we need to control, still in some extent through a manual approach. We tell ourselves that in order to create a useful AI-backed surveillance system, it must have these 4 features. It must be able to identify the event in real time, and then it must also be able to precisely predict the event in the future. Not only telling you there will be an increase of dengue outbreak, but tell you where at a 400-meter radius with 80% accuracy. So that is something that you can work on for people on the ground. It must also be able to prescribe the mitigation action, and then it's also be able to integrate various and large data points. So how we do it is simply like we combine all of those data that we usually collect, the epidemiology data, and also there are some socioeconomic data. We try to look into data that not mainly about the patient, but mainly about the social determinant of health, about where the patient live, rather than about the patient themselves. So that's part of it. So I think, like, just to cut it short, I will give you a short movie about how actually the system look like. Can you press play or like a space bar? Yeah. So I think there's no sound in here. So like what I have tell you just now, we try to combine all the random data that we get from heat, construction, weather forecast. And we build a powerful algorithm that combine all of these 275 data points. We crowdsource some of the additional data. So that it can give you like a precise area of where it will happen, and then it will tell you like how, right? So these are some of the data points and database that we subscribe, and mostly are not really about the patient, mostly are about the social and economic determinants, like I said just now, and we do all of this in less than 21 seconds. But I think we can skip all of this technical part. I think what's more important is like how to validate this technology. And of course, I'm a public health practitioner in the first place, so I'm very skeptical when the algorithm actually come out. So what we do is like we identify a neutral partner, which is the Institute of Medical Research. We ask our system to come up with a forecast, and then we ask the Institute of Medical Research to keep up this result. After 30 days then, and the site of study was in Penang, and after 30 days, we asked them to come up with their own report of outbreak, and we cross-validate it. And this kind of validation produce a field predictive accuracy at 81.08%. We replicate this model again and again and again, and across this area, we have managed to come up with an accuracy precision at 84% in Rio and Manila, while 81% in Kuala Lumpur. We publish this validation study, but like I said, like while we get answers to some, there's still more questions to be answered. And so I think like it's very important that we have this kind of symposium and we have this kind of workshop so that we can validate and start benchmarking AI solution. And to cut it short, we recently we have heard about AI for good. For recently, we rebrand our position from artificial intelligence in medical epidemiology to become artificial intelligence made easy. And we have used this approach and this solution to deploy a simple, meaningful, impactful solution in agriculture, aquaculture, and also in gender-based violence. Thank you so much.
So, one question. And I have a question. So, what do you think is more difficult, predicting a virus outbreak or the stock market?
I'm sorry? Okay, so I think we have a lot of that kind of question. So you see, there are entities that try to predict market trend, right?
Right.
And to answer your question, it's like we need to first, I mean, if we take a step back, let's understand the idea of chaos theory. There are two levels of chaos theory, right? The first level is a kind of prediction that doesn't affect the eventuality. This is like weather forecast.
But people are intervening. I mean, once you say there's an outbreak, you need to make it public for people to
yeah,
and then that changes your prediction.
That changes your prediction, yeah. And we have got a lot of this question, like many times, multiple
so
times.
We'll get to it. Thank you very much. Samir?
Can I ask a question on how do you apply machine? Yeah, how do you apply machine learning to this program that you have, the algorithms? Is it one-off, or how do you apply it on a regular basis to enhance the efficacy? And the second question is going back to Professor Paul's point about scaling. Where is the angle of scale? I mean, you've done it once, but I think it's very important to discuss scaling in AI. So how are you looking at that perspective? Thank you.
All right. So how do we apply the machine learning? Is that we use we are not married into one particular development model. So we try to be agnostic in our development. So for example, in terms of building the API and data collection, we build it using Python. If we are talking about the dashboard, then we usually use a .NET framework. And the idea where we use machine learning is like you integrate all of these various data points, something which is for example, if you ask any public health doctor here, right, I can tell you that weather is actually correlated to dengue outbreak. Construction site is correlated to dengue outbreak. But you don't necessarily ask the patient like, do you have a construction site behind your house? No, you don't do that. So what we do is like we subscribe to all the external database, put it all in one place and build an algorithm that can give you an insight of where it's going to happen. And the next question is the scalability of it. So and why we have like multiple validation model across the sites is because we have this kind of practice, like before we deploy the solution, we run a modeling in that setting itself. I know it works in Malaysia. I'm not very sure whether it will work in Manila. So when I go to Manila, I ask them to get the historical data, and then we try to see like whether it can give a good forecasting. And if it's good, then we deploy that. If it is not, like our discovery in some other setting, so we decide not to. So you must also be responsible in how you deploy it, I suppose.
All right, thank you very much. We have to move on. Sorry, please hold the questions on the plate. Our next speaker is Shantanu Pathak. Shantanu, please.
Good morning, everyone. As Deepak mentioned, the advantage of participating in health conferences is you get a doctor tag in front of you. So I'm not a doctor as well. I'm a PhD scholar and also co-founder of a pregnancy care company called Care Mother. We are a digital health company and trying to improve the healthcare delivery at last mile with the help of digital health solutions for remotest part in India. My focus of talk is on more maternal health perspective for India. Just to give you 2 pointers on that, we have around 2,000 pregnant women behind one gynecologist, and there's a network of more than 1 million community health workers or auxiliary nurse midwives who are primarily giving services to pregnant women. Despite of reducing the maternal mortality ratios and infant mortality ratios, we are still struggling the quality of care that every pregnant woman receives in majority part of the India. And out of the 30 million pregnancies, those occur in India every year, around 20 million pregnancies are still struggling for the quality care. So with that focus, I would like to focus on Prabhati Tai's story, a health worker from one of the village in Aurangabad district in Maharashtra, state of India. She was trained with the digital health solutions that we had offered, and sometimes we are not also aware what kind of situations can help this health worker by empowering them with the smartest tool. She used a digital portable fetal heart monitor for NST. She was having a regular antenatal checkup for high-risk pregnant women in the remotest village. She could identify that mother is not having a heart rate above 100 beats per minute, and typically the range is 110 to 160 beats per minute. Now, the app flagged her into a high-risk condition, which is also by training they are aware. Now, having the availability of this device helped this health worker to refer this mother to a facility and avoid all other communication with a medical officer who is probably not available at the primary health center. She referred this mother to a direct tertiary facility where she was monitored for a while. Doctor identified the baby is in critical condition. She was done with a C-section and baby was saved, and naturally it helped mother and the family to have a severe trauma with the stillbirth condition. Now, this was to a surprise for a doctor how a health worker who is Asha, he's not also A&M, took this decision. And what we feel, that's where technology can help. If you want to talk about scale, reaching out to the last mile, technology can really empower Prabhavati like health workers to ensure that conditions are identified at earlier stage and a triage is possible with use of technology. So involvement of these people is equally important. So what Care Mother does is having a platform with point of care devices, a mobile application designed and simplified for the use of the community health workers, identifying or using the basic decision support tool to identify risk condition at early stage and triaging those patients at the required facility. We also have a portable device for fetal heart monitoring and labor monitoring. Typically, these machines are available in tertiary facilities, and identifying conditions of fetal asphyxia or babies having a low oxygen supply, or even labor monitoring when they are transported from one place to other place, we require portable machines. But just having machine doesn't help. How that health worker or the doctor who is not a gynecologist or trained physician understand the conditions, where to report. Now that's where machine learning helps to identify the conditions and help these health workers to take certain decisions. So we have been implementing both the solutions step by step, tying the data, trying to improve the quality. The solution is now being assessed by Ministry of Health also for the further recommendation, and ICMR was also asked to submit a proposal for being a part of WHO's revised recommendation for quality antenatal care visits. Now, what we learned, ultimately, these are the people who are reaching out to the largest population, how we can involve them, where actually AI and the capability and the capacity building of these health workers can be combined. And simple use of technology, the devices which they are aware of, the devices with which they can be trained, and the software application, how we can identify the problem statements in the maternal and child health perspective. And that's where we are trying to focus upon how we can have small but simple decision support tools where health workers are empowered to make the decisions, also predict high-risk conditions or preterm birth. Again, these are the components which are very simple, but in terms of preterm birth, we do not have efficient biomarkers available as well. Can we use this data available with us to achieve these problem statements? Importantly, auto-interpretation of the fetal heart conditions as well. So these are very specific problem statements that we are targeting with the help of availability of the platform, the devices that we have, and trying to apply the machine learning for it. So the studies are in progress, but we are also seeking partnerships here with various organizations. What I'll talk about is the limitation when we want to do such studies. We already mentioned, Mr. P.K. Sinha mentioned about the availability of smartphones and the data that we have in this country now. The positive story is all the Anganwadi workers or the ANMs are being equipped with tablets now. Of course, the data is the crucial component of it. So somewhere now we have a platform or infrastructure being laid out. We have health workers network, and I would say we are in the sweet spot of opportunity to generate the data. But the challenges are immense. Also, to further expedite or understand how the patients or families can also participate in generating the data. So that is one component we can definitely look forward. While building that, how exactly we understand that whatever we are building, we are designing for these people. The reason I'm bringing this point is, being an engineer, I started building, a very prediction model of high-risk pregnancy, and I wanted to implement that solution in healthcare delivery system. First thing I had to do for last 2 years, unlearn what I meant and learn what public healthcare delivery system is. And that's where my learning came in, that whatever we are designing, are we designing for them? And the perspective is, when we are designing for the Anganwadi workers or ASHA workers, are we aligning the motivational incentives as well as the capacity building of these health workers where technology is combined? Also, one of the approach typically done from the top down approach, that we want to have reports and quality data marked with proper reporting styles that we have to submit or make the presentations, versus are we building the solution which can be used by this health worker and can be used for intervention there itself. So micro utilization of the data and the utilization of the AI tools which these health workers can use. Again, the moment we talk about the data, already people have spoken about it, but accessibility of the data or the capacity to generate the data versus the maturity to use the AI tool will be an important factor for us while designing the system. And a lot of aspects are there. The quality of devices we are using, the biases, those are built while getting the data input, and also on the control of the test or building the model. So what we learned on benchmarking process from the ITU, that will be really helpful. And now the system caution will be reporting versus intervention aspect of the previous generation versus the AI building model or the building of AI models versus the deployment of AI for applications will be an important aspect. This is my last slide. What we learned of reaching out to more than 1,000 villages from Mumbai slums to the northeastern of India, to build an AI from our kind of solutions or the effective tools, we need the sites or the places where we can test our AI models quickly. Can we have a quick collaboration platforms where whatever we are building or generating can be collaborated and plugged into the system? So until unless we have a large level framework, whatever we build will be built in silos, and there will be a lot of duplication of work which is being happened in various parts of the world as well. So this platform actually can offer this facility, and I'm sure with the working groups that will be really helpful thing. So the last but not the least point, having the priorities listed will be very important aspect. And for this group, I didn't see a maternal health group inside the list of the 15 or 16 topic groups, but for a country or for the world, this is one of the important area, and why not we should start on that front as well. Thank you. Thank you very much.
One question. Yes, please. Use the microphone, please, because we have remote participation and they will not hear you if you don't use the microphone.
Yeah, so you're deploying this in remote areas. Is it cloud-based AI that you deploy?
So we use the machine-based algorithms only. So not necessarily we are reaching out to cloud for every component of it. For some normal decision support tools, we are using app-based tools itself. So not linking to the cloud. So even if there is no network, they can make the decisions.
Primarily a rules engine.
Yes.
Thanks.
All right. Thanks. Thank you very much. So our next speaker is Anjali Agrawal. And I'm glad we have our first female speaker now. It's about time. Thank you.
I hope I'm visible.
I hate
that, when I can't see the audience.
If you want, you can sit next to me and do it from here. It's up to you.
I think I'll be all right. If that's okay with the group? Yes.
It's your choice.
Thank you. Yeah. Hello. So I'll be talking about AI in radiology, and I want to first thank the organizers for inviting me and thank my chairpersons, Dr. Weigand and Dr. Chandrasekhar. I work with a group, Teleradiology Solutions, which is primarily a teleradiology service provider. It provides its services to India and many countries across the globe. I also happen to be involved with the Society for Emergency Radiology. And our group has taken a plunge into development of artificial intelligence algorithms because of various reasons, which I would just go through over the next 8 minutes. There are many challenges that we face in the field of radiology, and that's true for the rest of the healthcare system as well. In radiology in particular, the imaging volumes have really multiplied over the last decade or so. The reason being there are a plethora of modalities. The algorithms, the protocols have changed drastically in keeping with the sophisticated treatment plans and more individualized treatment options that are available. There continues to be a shortage of radiologists, and it has not improved in the last decade for sure. In fact, the shortage is even more acute than before. Here is a kind of a rough idea of where India stands. In fact, currently, the ratio is so skewed. You have less than one radiologist for a population of 100,000. And you can compare it to the US and Europe, and it's worse in Bangladesh and Nepal. there is a huge demand-supply mismatch. Taking India, for example, I mean, as it is, we have a huge shortage of radiologists. To make situation worse, most of these radiologists are based in the big cities. So that's true for the rest of healthcare as well, almost 90%, compared to a population that's almost 70% that's residing in rural India, leading to a huge mismatch here. However, the expectations are not low on either side, be it from the referring clinicians, from the radiologists, or the patients who are coming for their imaging examinations. They all want quick results, good images, and of course, accurate interpretations. And the reimbursements have been diminishing on a global level. Perhaps not that true in India, barring the conventional modalities of radiography and ultrasound. To the extent that many radiologists that I know, many of my colleagues would not like to read plain films because the reimbursements are abysmally low. So to make up for these mismatches, the radiologist shortage, huge demands, the radiologist traditionally is visiting many hospitals, spending a few hours providing consultation at multiple hospitals in the neighborhood or across the city. And what makes it worse is, traversing these almost impassable roads in the city of Delhi, and that's true for many other cities and tier 2 cities as well. Now, all this is basically just a recipe for, it's a disaster. It's a recipe for burnout, which is rampant in the radiologist community. I'm sure it's true for other specialties in healthcare as well, but I know for sure that in radiology, we are facing this crisis. We just have to find ways to overcome this particular drawback. Teleradiology is one such technology which is able to bridge the gap between supply and demand, in the sense that the images acquired at one position can be transferred to the radiologist irrespective of the location of the radiologist, be it in the hospital, at home, or anywhere in the globe, and also be able to provide images directly to the clinician or to the surgeons in the operation theaters. However, we've also demonstrated that this teleradiology is feasible for rural India, such as teleradiology services that were provided to a missionary hospital in the state of Arunachal Pradesh. And this was written up in 2007, demonstrating feasibility of teleradiology in India, which has very few radiologists for a population, just 2 for a population of 1 million. However, teleradiology can, bridge these gaps only to a certain extent. Just giving the example of our group, which is an international service, teleradiology service provider, it's probably a boon for the developing world, which is able to harness the skill of radiologists, highly trained radiologists, no matter where the location is, taking advantage of the reimbursement differential. However, it may not be a boon, might be a bane for the developing world, where the reimbursements tend to be low, and radiologists might prefer to read for the developed world. So, despite the fact that teleradiology has brought about major changes in the practice of radiology, the shortage of radiologist workforce continues, and artificial intelligence attempts to bridge that gap in the supply and demand mismatch. It promises to improve the entire radiology workflow, right from the acquisition of images to image reconstruction, processing of images, their analysis, diagnosis, and also in terms of prognostication and guiding treatment. In fact, the impact of AI is felt even before image acquisition in terms of providing clinical decision support tools to the referring clinicians as well as radiologists in terms of designing a protocol for a particular disease entity. As far as the image acquisition goes, I think the major benefit when it comes to the Indian setting is maybe decreasing imaging time. Of course, it has other advantages in terms of decreasing radiation contrast doses and reduction of artifacts. For example, now, it's possible to acquire an MRI in a short time span of 10 minutes, say for the lumbar spine, because algorithms have been developed that can enhance noisy, very grainy, undersampled MRI images. And you can produce diagnostic quality images in very short time frames. And this could increase patient throughput. We are all aware of the fact that there are patients who are suffering from malignancies that are waiting for the MRI scans for almost like a month in the big institutions, tertiary care centers. Perhaps we will be able to overcome that particular problem. A few use cases from our group. We have developed AI algorithms for mammography screening and diagnosis, as well as in cases of hemorrhagic and ischemic strokes. Just a few examples. In terms of detection of intracranial hemorrhage, we have worked on this algorithm where the algorithm can actually pick up very subtle hemorrhages, which can be missed by a novice radiologist, and therefore bridge gap between the experienced and not so experienced radiologists. This tool has been integrated in our workflow, which is extremely busy. At any given time, I have like 25 cases on my work list, and I need to be able to prioritize those cases. I've had instances where a case with a big bleed was sitting at the bottom of my list, and by the time I called, the patient was coded. So these cases are flagged as red, or they're color coded, and there is a tooltip summary when I click on those cases. In terms of, there are also other aspects of head CTs that we are looking at in the emergency setting, such as fractures, the volumetrics of hemorrhage, which would determine the prognosis and treatment, and also artifact elimination, as well as generation of a structured report. For mammography screening, as we all know, that breast cancer is the #1 cancer in India currently. It has surpassed cervical cancer. And we need to be able to screen these mammograms effectively and very efficiently. And this particular algorithm helps us do that by assigning the correct BI-RADS category and eliminating category 1 and 2 from the radiologist work list. A few examples of how this algorithm works in terms of sizing, defining the shape, location, and density of breast lesions, and generating a report. Plenty of work has been done on tuberculosis. We studied one particular feature that I'm showing is that of pleural effusion, where the detection was done based on differences of height, the different lung bottom curvature, and the variation in the lower lung intensity. There is going to be a talk by Cure AI in the afternoon session. I'll not go into the details, but they've done a fantastic work on automated chest X-ray screening for tuberculosis. This has also been implemented in fracture detection with heat maps, kind of trying to give us an idea as to what pixels are contributing to a particular decision making by the algorithm, and hopefully providing some insights into the black box and making it not that black. Ultrasound remains the core and the first-line diagnostic imaging modality, and it has many applications. We also have many opportunities when it comes to automation because the devices have been miniaturized, there is growth in compute power, and the applications are numerous because it is a point of care diagnostic modality, and it is done in real time with no radiation exposure, and it's relatively inexpensive. Just an example of this particular probe that is attached to a smartphone, where the images are acquired real time could be acquired by the emergency room physician under guidance by automated algorithms in terms of acquisition of imaging as well as diagnosis. A big plus in the ER setting. However, I just want to throw in a word of caution. Technology can only enable. Intent is key. And female feticide could be an unintended consequence of technology that may not be used in a responsible manner. So one has to be careful in our setting where this is a huge problem. Then the black box systems, which have not been trained on Indian data sets, such as the CAD4-TB, which failed on Indian chest X-rays because of different texture of lungs. Of course, quality control and monitoring is something that we all need to look into, and I think we will be deliberating on this issue over the course of the next few days. And hopefully we'll be able to come up with some interesting and constructive ideas. And just a big thanks to my team at Teleradiology Solutions, and thanks for your patient hearing.
Thank you very much. One question, please.
My compliments to you for an excellent presentation.
Thank you.
I'm not a doctor. I'm an engineer, and I come from Department of Telecom. I'm in the standardization business, and we work very closely with ITU. So probably this is the right forum to air this view. Now, what I find is that most of your radiology images, they are these DICOM images. They are stored on PACS standards, and they are usually not understandable by non-PACS platforms. So every time you're given a CD or a DVD, or else if you go to another hospital, you're supposed to carry those big radio images. So I think what the need of the hour is that if you can have some centralized, the hospitals should invest in vendor neutral, these kind of images which are standardized and they can be accessed by all hospitals, all patients. So that, and you can centrally monitor that. So I think we need to work on standardization of storing of these images. Yeah.
Radiology images are DICOMs. They follow the DICOM standard. And when you get your imaging examination done at any of the diagnostic centers, you get your DICOM images on the CD. And you could use and there are many softwares that are freely available on the internet. So you could sometimes they provide you with the DICOM software as well to be able to view your images. And your point is well taken. Yes, we need to have standardized storages, and all these AI algorithms that are being developed should be, neutral to any kind of brand. They should be, sort of brand agnostic, and you should be able to operate them no matter what your PACS or what your which brand of ultrasound you're using or you're using. Yes.
Thank you very much, Ken. Thank you. So our last speaker for the session is Rainer Berger. Please.
Okay. Hi, good morning. My name is Rainer. I'm from AI Singapore. And this morning, I just want to introduce you to what AI Singapore is, what we're doing, and also about what we're doing, particularly in healthcare, which is what we call AI in Health Grand Challenge. Okay. So AI Singapore is a national program funded by the Singapore National Research Foundation, and its aim is to foster the use of AI in Singapore. So we are physically located inside the National University of Singapore, but we actually work with all the different universities and research organizations in Singapore, and we work closely with different government bodies like EDB and IHIS. In Singapore, IHIS is the body for digitizing the healthcare space and also ensuring that the connectivity and data exchange between the different healthcare providers. AI Singapore is divided up into 3 pillars. So we have an AI research pillar, which is basically giving out grants to promising AI researchers. And we have an AI innovation pillar, which is focused on 2 parts. There's an education part where we have an AI apprenticeship program for to train up the skills in Singapore. And we also work with local companies on different projects. So if a company has an idea for something where they might apply AI, they can come to AI Singapore and we can work together to develop and deploy their first AI solution. The AI technology pillar is more for national type of projects. So for the national type of projects, which we call grand challenges, they're supposed to be large projects which address important issues for problems faced by Singapore or the rest of the world. So the first grand challenge that we've actually launched is for healthcare. And next year we're launching another grand challenge in terms of AI for education. And in future we'll have other challenges in terms of the urban landscape or finance. So the idea of a grand challenge is it's supposed to be inspiring. So besides just delivering the particular deliverables, it's also supposed to open up people's minds, get them used to the possibilities that might exist of using AI for different domains. Okay, and it's supposed to have a measurable impact for the nation. So for AI in Health Grand Challenge, we got all the different stakeholders together to brainstorm what might be the problems to be tackled as part of this grand challenge. And the problem statement they came up with was about how using AI to help primary care teams slow the disease progression and complication develop in 3H patients. So it's talking about high cholesterol, high blood pressure, diabetes. These three are the top 3 chronic diseases in Singapore. So they actually account for the majority of visits to polyclinics. And there's 1.5 million residents expected to suffer from one or more of these chronic diseases by 2020. And that number will go up as the population ages. So this was considered to be the most important problem that maybe AI can address for Singapore. So the Grand Challenge is actually a 5-year program run over 2 stages and involves $25 million that AI Singapore is giving out. And we encourage multidisciplinary teams and partnerships and consortium to address these particular problems. And international collaboration is always welcome. Besides the problem, so the problem statement was to reduce the complications by 20% over the next 5 years. An aspirational goal would be to reduce by 50%. And they've also done work to put aside measurements of how we're going to measure how the impact in the future. So to establish some baseline measurements and how to measure in the future what impact has actually been achieved. So for the AI and Health Grand Challenge, there were actually 3 teams that were selected to work on that. So the first team is using predictive analytics for early screening of 3H patients and also for risk stratification. And it's able to adapt the treatment regimens based on the people's lifestyle and their medical condition. The second team is actually developing devices that can be used in a community setting. So the devices can provide tailored preventive advice and lifestyle coaching, as well as analyzing the food and diet intake of the people. And the third team is developing a mobile app that can be used by the general public. It can be used for periodic monitoring of 3H patients and also for identifying pre-3H patients based on their behavioral patterns and medical status. The mobile app will use things like peer support and gamification type of ideas to keep people engaged and keep them using the app. So we have 3 different teams looking at taking different tracks for addressing the problems of reducing the complications arising from 3H. Okay, so besides funding these 3 different teams, AI Singapore is also looking at the data issue. So we're also building a micro-access lab, which is a secure facility for accessing the healthcare data. The healthcare data is very sensitive, and the researchers are not able to access that very freely. So we have built a secure facility where people with AI researchers can actually go in, train their machine learning models and so on. And then they can take out the models that they have trained, but they're not allowed to take out the data of the healthcare data. And we're also looking at providing a federated database of combining all the different data that is needed by the 3 teams together from all the different healthcare providers. In terms of the IP, the purpose of the Grand Challenge is also to produce practical applications, and the teams are encouraged to commercialize it. So the teams could continue to work on it, try to commercialize it, or tie up with some commercial partners to get the products or the innovations that they have developed out into the field. So we are also very keen to collaborate with other people who are working in AI for health, and you can actually go to the website and register for the collaboration. It doesn't have to be about 3H, it could be about other aspects as well. And that's all.
One question? Please. Use the microphone for the remote.
Sorry. The last point you mentioned about this data access framework, is this already operational and you use this, or is this an idea that you are driving for?
Okay. Actually, the renovators are still in the process, so we actually have got the lab. We're building up the lab right at the moment. The renovation should be finished in December, and then in the meantime, we're talking to people like IHIS in terms of the data, what type of data that the people will be able to access from that.
Thank you very much. That concludes our session. Thank you. We made up 8 minutes over that. So are we?